Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at our Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions along with the Ontario College of Family Physicians. And I'm going to turn it over to their president, Liz Magad, to introduce the session. Liz?
Thanks, Tara. So great to be here with everybody. As Tara said, we host these sessions together. We have three terrific panelists. We're going to really talk about what is top of mind from COVID to monkeypox. This is MainPro accredited, so you'll get an email about that. You need to, with instructions on how to submit to get your credits. The next slide is the land acknowledgement. So I'll just read that. We acknowledge the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. I'm calling in from Ottawa, which is unceded Algonquin and Anishinaabe territory. And I just wanted to share with you, this is a new, if you just go to the next slide, this is a new information that has been created by Dr. Erin Peltier. She's one of ours, a family doctor working up in Sudbury. She's also the regional Indigenous cancer lead. And this is a series of videos that she has created in Ojibwe, Cree, English, and French about cancer screening. And they're really terrific, actually. So I will give you the link to that and you can take a look at it. Really great to share with your patients, and just a reminder of the need to be focused and intentional in terms of our screening efforts for our Indigenous populations. I'll send that back to you now, Tara.
Thanks, Liz. As usual, you'll receive a completion of MainPro credits following the session, and all our sessions are recorded. And these sessions build on each other. So we won't be talking, for example, a lot about Paxlovid today, but we've talked a lot about Paxlovid in the last two sessions, and you can find out more about that by going to the website there. Next slide. Really excited about our panel coming up. Next slide, and grateful for continued co-hosts. Next slide. I'm going to turn it over to our panelists one at a time to introduce themselves. So Jeff, are you able to go first?
Yeah, sorry. Yeah, so my name is Jeff Kwong. I'm a scientist at ICS and a family doctor at Toronto Western Family Health Team. My relevant disclosures are that I received grant funding from those CIHR, Health Canada, and the CDC. And also I've received an honoraria from the OCFP for giving these talks.
Thanks, Jeff. Gerald?
Yeah, hi, Gerald Evans. I'm infectious disease specialist at Queen's University Kingston Health Sciences Center. My only disclosure since I'm going to talk about COVID-19 is I am one of the members of the Ontario COVID-19 Science Advisory Table.
Dan?
Hi, morning, everybody. Daniel Warshawski. I'm an Associate Chief Medical Officer of Health in Ontario, and I have nothing to disclose.
David?
Good morning, everybody. I'm David Kaplan, family doctor in Toronto and Vice President of Quality at Ontario Health. And I receive a stipend for guest hosting these sessions, as well as salary support from Ontario Health. Morning, everyone.
Liz?
Thanks. So I'm a family physician in Ottawa, and I am the president right now of the Ontario College, and I receive a stipend for my work as president. Thanks.
And I'm Tara Kiran, and I've just listed here some of the places where I've received salary support or research grants, as well as honoraria, but none of them pose a conflict for today's talk. Next slide. I realized I forgot to fill out this outline for today's slide, but I'm going to tell you what we're going to have in store. We're going to start with Dr. Jeff Kwong, and Jeff is going to take us through his latest research on vaccine effectiveness. And then we're going to move to Gerald Evans, who's going to tell us where we are at with COVID and dive deeper into that evidence around third and fourth doses and how we should be counseling our patients. We're then going to break for a little bit of Q&A related to COVID. And then in the second half of our call, probably around 8:35, we will be turning our attention to monkeypox. We'll have Gerald give us a little update on where we're at with monkeypox. And then we're going to go to Dan Warshawski, who's going to tell us a little bit more about the provincial context and some practical pieces of case definitions and what we need to do. Of course, as usual, we appreciate you putting your Q&A into the Q&A box. Please use the chat all you like to connect with yourselves, to react, to network, provide resources, but put your questions in the Q&A box, and that way I'll be able to prioritize the ones that get the most thumbs up. So best to thumbs up a question you like rather than ask something that's similar but differently worded. Next slide. So without further ado, I think I'm going to turn it over to Gerald Evans. Olivia, are we able to go to the next slide?
No.
Perhaps there's a problem with the slides, not sure. Oh, actually, sorry, I'm turning it over to Jeff. I wonder if Olivia, there's a problem with Olivia's slides. So let's give her a minute to figure that out. So I know, Jeff, your section is pretty visual, and you were going to start with some slides. I don't know if there's anything that you can start with prior to having, oh, there we go. Olivia's figured that out. Perfect.
Okay, yeah, great. Next slide, please. So I'll be talking about vaccine effectiveness in adolescents and children. So this is work we did where we used data from November 22nd, which was when Omicron was first detected in Ontario, till March 6th. And we looked at effectiveness of 2 doses and then the third dose in the 12 to 17 year age group. And so you can see on the left-hand side, this is against symptomatic infection. So the black squares are VE against Delta, and you can see it goes over, goes kind of lower slightly over time from a peak of 97% down to 90% at about 6 months after the second dose. Whereas against Omicron, it never is as high as Delta. So even after 2 doses, it's 51%, and then it goes down pretty quickly, even by like 60 days after the second dose. And then, by 180 days, it's only at 29%. And then when you get a third dose, then it goes up to 7 or more days after the third dose, it went up to 62%. So there is, it's slightly improved with the third dose, not fantastic. But that's how it is against Omicron, even with 3 doses for infection. Now, against severe outcomes on the right, we were able to only estimate it after 2 doses. And overall, for 7 or more days after 2 doses, it was 85%. There just weren't enough hospitalizations or deaths in this age group during this time period to look at it after third dose or, broken down by time. Further, you can see all the estimates after the second dose are the confidence intervals are pretty wide. So this is posted as a preprint if you're interested in reading more about it, and it's in press in pediatrics. Next slide, please. So moving on to the 5 to 11, we all know that we've had large Omicron waves, and particularly in the 5 to 11 age group. So you can see on the right there that one line, that kind of orangish line that stands out against the rest. That's the 5 to 11 age group. So they've been hit particularly hard by Omicron in the March-April period. Next slide, please. And here's vaccine coverage in 5 to 11. So you can see that the program started around the same time that Omicron came in. So the week of November 22nd was when this age group became eligible for vaccination. You can see that there was a rapid rise of first doses in that dark blue line. And then the second, with the second dose, there was a more gradual increase. And so it makes sense because there was, changing in the recommendation in the interval between doses. There were some people who got their second doses early, at around 3 or 4 weeks. And then, but only like 4% had that, interval of 15 to 27 days. And most did have the interval of more than 56 days or more, which is 8 weeks, which is what's recommended. But you can see that there's still the second dose, coverage is still substantially lower than first dose coverage. So we still have quite a ways to go in getting, this is only till the end of April, but I don't think that there's been a massive increase since the end of April. Next slide, please. So looking at VE in this age group, so we looked at the period from January 2nd to April 30th, and we picked this period because this is after the restriction to PCR testing. And so just to make it more even, so what happened was before the PCR testing, there's a lot of more kids getting tested. And then after January 2nd, it became much more restricted, and we were aware that that might change our estimates. So just to make it more, a consistent period of time, we picked starting from January 2nd, and we went till April 30th. This is still something that we're working on. We're close to finishing this, but here's what we got so far. So on the left, we've got VE against symptomatic infection, and on the right, we've got VE against severe outcomes. So we've got it against 14 or more days after the first dose, and then 2 periods after the second dose. So 0 to 6 days or 7 days or more. And so you can see that the VE, even after the second dose, is not very high. It's 47%, but definitely higher than the first dose at 15%. And so the takeaways are that, 2 doses, definitely better than 1 dose, and that VE is higher against severe outcomes, as you can see on the right, 87% after 2 doses compared to against infection. So, very consistent with what we've seen with other age groups, even with the, the lower dosage for this age group, lower dosage of vaccine for this age group. Okay, so, this is pretty straightforward, and, this is kind of like, this is kind of what we expect. But then if we can, we did some further analyses to kind of break these numbers down further. So I'm just going to ask you to go to the next slide, please, Olivia. So what we did was we looked at waning after each dose. And so you can see on the left, days after dose 1. So we have like 14 to 29, 30 to 59, and then 60 days or more. And you can see there's definitely waning going on there. And then after the second dose, you can see some waning as well. So it seems to peak at 7 to 29 days at 64, but then it drops off, by 30 to 59 days, and then 60 plus days or and beyond. Maybe it's plateauing. And then against severe outcomes, there's also the trend, of waning against severe outcomes as well on the right, although the confidence intervals are very wide. So just because there are very few severe outcomes in this age group. Okay, next slide, please. Now, what's interesting is in Ontario, because there was the recommendation to give the second dose at 8 weeks, but there was all kinds of variability happening, and because we have a relatively large population, we're actually able to estimate VE by these different dosing intervals. So this is a VE against symptomatic infection only in the kids who received 2 doses, and we broke it down further by how many days there were that passed between dose 1 and dose 2. And so you can see a trend here where shorter dosing intervals seem to be associated with lower VE compared to longer dosing intervals. So, at 56 days or more, the VE happens to be 56, whereas if you had a very short dosing interval, then it was only 10%. And so, this is, people like this is why NACI actually recommended a longer dosing interval, is based on the immunological principles. With a longer dosing interval, you allow for better VE because the first dose kind of stimulates an immune response, and then you kind of give it time before you give the second dose. And so it's quite interesting to see such a big difference in the VE here. And we've done a number of investigations to see if this is a real thing, or if this might be due to kind of differences between the groups that the models can't account for, so otherwise known as residual confounding. So one obvious explanation is that, well, the people who had longer dosing interval, it's been a shorter time since they got their second dose, whereas people who had a shorter dosing interval had a longer amount of follow-up time. So maybe that's all it is. It's just kind of like more waning after the second dose. So what we did was we broke each of these periods down further. So if we can go to the next slide, is within each of these groups, we looked at the different time periods since their second dose, And so you can start to see in each cluster of those lines there, you can see the waning over time. So that, the highest VE estimate is for the 7 to 29 days, and then it kind of goes down at 30 to 59 days, and then 60 days or more. So between the black down to the blue, down to the red. But you can still see that trend where, even, kind of like, taking into account the amount of follow-up time, that the longer dosing intervals is associated with higher VE. So if you follow all the blue squares, for instance, there's definitely an upward trend. And if you look at all the red triangles, there's an upward trend going from left to right. So this suggests that, longer dosing intervals is a good idea. But the thing to keep in mind is, like, in between dose 1 and dose 2, you could actually get infected. So, so it's kind of a trade-off. And so, if there's like low incidence of COVID, then it definitely makes sense to have a longer dosing interval. With a shorter interval, with a lot of COVID circulating, it's definitely, there's a lot of other considerations. So maybe one of the intermediate groups, might be kind of a compromise. So that's all I have to say. This is what we're been working on in terms of vaccine effectiveness. Thanks.
Thanks so much, Jeff. There are actually like a few questions specifically for you that I might go to before we go next to Gerald. So Afsane Afsar asked a couple of different questions. So one question she asked was, Dr. Kwong, many patients, especially children and adolescents, have mild symptoms, and many cases were not reported because they do tests at home. How can vaccine effectiveness be assessed if cases are not reported?
Yeah, so we're using what we call the test negative design. So the ones who do get tested, who do get PCR testing, will be included in the study. But definitely that is a huge concern, that we're missing a lot of cases who either don't get tested or have a rat and never show up in the provincial data. But that's, that's why we started the study period on January 2nd, just to be more consistent. So, the people who are getting tested, they're either like really sick and, are kind of bordering on needing hospitalization, or, they're in emerge and they may need hospitalization, or they're a child of a healthcare worker and they had access to PCR testing.
Hal Braden asks, how many children in Ontario, absolute number and percentage of those who get COVID, are getting severe outcomes from COVID? I don't know if you can answer that, Jeff, because it obviously relates.
Yeah, I don't know the exact number off the top of my head, but it's a very small number. That's why you can see those, all the severe, we are capturing just about all the severe outcomes here, right? Because, any kid who's getting hospitalized would be getting tested. And you can see that the confidence interval is very wide, but, we're talking about like definitely fewer than 100 in the whole province over this time period. So in the kind of dozens, maybe.
Gerald, did you wanted to add to that?
Yeah, it's about 2%.
Okay.
About 2%. We see hospitalizations and then you can use that as a surrogate marker of severity of disease.
Kimberly Wintermute asked, does the VE per dosing interval account for the possibility of some of the kids may have had the illness between doses, Jeff?
Yeah, that's a very good question. That's definitely something we considered. Unfortunately, we have no way of showing that, because a lot of them are getting tested by rats and they never show up in the data. So we just don't know. But that's a possibility, is that the people who waited longer got an infection in between, and that's why it looks like they're more protected, because it's like they've, by the time they got their second dose, it's like their third exposure to COVID.
Yeah, so I think there's some similar questions. There's actually some very specific questions about your research, Jeff, and I might ask you to answer some of them in the chat. But I'm gonna ask a couple more. So Diana Ahmed says, can you comment on the negative VE, which is noted after several months in several studies? Your intervals are very short and many patients wonder what happened after months following the vaccine, not just short term.
Yeah, the negative VE estimates that we saw in Ontario were happening right when Omicron was first introduced, like kind of in November and December. And it was the outcome was infection. And we think there's a number of reasons why it is. So you remember that we had the vaccine passports in place. So people had to be double vaccinated to go into like restaurants and bars and sporting venues. And so what happened was, Omicron was brought in by travelers, right? Because, it had to be brought in from somewhere else. And, travelers had to be double vaccinated. And then, probably their household contacts and social contacts were more likely to be double vaccinated. So it's kind of just circulating amongst the double vaccinated people at first. And and then the people who are vaccinated are also more likely to go get tested. And so that's why it looked like, if you're double vaccinated, you're much more likely to get Omicron. Well, it's because they're more likely to get tested and be detected as Omicron, and then it's also more likely to be circulating. But since then, now that it's diffused to the overall population, we haven't been seeing the negative VE estimates. So I think it was just this kind of funny period where you had this immune evasive variant circulating in a highly vaccinated population and making it look like the vaccine doesn't work. And that's one of the challenges with these observational studies, is that you can sometimes get these funny kind of results.
Thanks, Jeff. So the vaccines, I think the data you showed are definitely helping, especially for severe outcomes. And I think that's definitely a bottom line there. The last question that I'm going to ask is from Afsana Afsar, who says, do you foresee a combination of flu and COVID vaccine in the fall?
Not this fall that I'm aware of, because we would have known about that, but maybe in the future. With that's the nice thing about the mRNA technology. I think that that is definitely something that is hopefully, I don't know if Gerald has any comments about that, but hopefully we'll have that in the future.
Yeah, and just while Gerald's commenting, Olivia, maybe you could bring up Gerald's slides. Yeah, go ahead, Gerald.
Yeah, just a very quick one. Novavax, which has a recombinant subunit vaccine for COVID, is currently finishing off its regulatory approvals for a combo flu COVID vaccine. Whether that'll be available by the time flu season starts, everyone knows it's about October 1st, we start vaccinating against influenza. But I think Jeff's right, it'll probably be a double shot. I think adults are just going to be able to get all the things that kids love about, having multiple shots and stuff like that. But in the future, for sure, there's going to be combined COVID flu vaccines. I think it's the best way to sort of handle things moving forward.
Wonderful. So Jeff, if you could go into the Q&A and maybe answer some of those specific questions that people have. People were very engaged in what you presented. And I'm going to turn it over to you, Gerald, to give us an update on COVID and then do a deeper dive on some of those vaccine third and fourth dose issues.
Sure, happy to. Thanks again for having me. So I'm just going to run through what is sort of a snapshot of what's happening right now, although I did submit the slides yesterday. So this is yesterday's data. Sometimes I have today's data. So this is active COVID cases as reported. Everyone knows, of course, we don't test as frequently as we did or as extensively as we did prior to January 1st. But you can see this downward slope in what I'm calling the Omicron #2 wave, with active cases now falling down towards 10,000. And yes, you can apply a multiplier to that if you feel like it. Maybe 10 would tell you exactly how many we have in the province. Next slide, please. This is just a 7-day running average, and you can see in the middle here, it doesn't look like a very smooth curve. That's when they ran into all kinds of data reporting problems, but it looked like we hit a peak of about 3,500 new cases per day just in the sort of early half of April, but it's now plummeted, and yesterday was down to 995. Next slide, please. I put this up really kind of to remind people. I'm still getting people calling me and saying, which wave are we in now? And it depends if you like a numerical scale, like 1, 2, 3, 4, 5, 6, in which case alpha here was 2, early Delta and late Delta. We got late Delta here where I live in Southeast Ontario. There's Omicron #1 and Omicron #2. So that's kind of what it looks like. The little red you see in the bottom here is because I'm a bit biased towards looking at Southeastern Ontario, since that's where I live and work. And that's our contribution to the provincial averages. Next slide, please. This is a sort of estimated reproductive number. As you know, it's harder to do now because we don't have full case numbers, but you can see that after that sort of blip in late March into early April, where we were above 1, we've actually fallen below that. And although it looks like, well, we were there too in February, it's important to remember in February, we had lots of public health measures in place. So one would expect the reproductive number to have fallen at that point because we had a lot of interventions. So it reaching the same level now with the withdrawal of lots of mandates out in public, it would suggest that we're actually getting a substantial improvement. Next slide, please. So let's look at hospital occupancy. One of the things that we've monitored, you can see these funny little blips here is sort of two, that's Saturday, Sunday. And if you look at the most recent blip down, that's Saturday, Sunday, Monday of the holiday weekend. But you can see this nice gentle drop in hospital occupancy. Blue is ward, red is in critical care beds. And so that's tailing off as well, expected to sort of lag a little bit behind the active case numbers. Next slide, please. So if you look at hospital occupancy on those waves, this is what you kind of get. You can see that in general, ICU numbers were highest with early Delta and then had a little bit of a blip in Omicron, purely related to the fact we had such large numbers of cases that even a smaller percentage of people with critical illness ended up driving bed numbers. But Omicron 2 wave has not been substantially that high, and that's good. But we still have seen hospitalizations. But Omicron second wave, which we've been experiencing and are coming out of now, really only got to the peak we saw with Alpha way back in early 2021. Next slide, please. So if you smooth out what's been happening recently, back in March when we had a sort of a minor lull, we got down to about 603 people in hospital with COVID, and it peaked actually upwards of around 16 to 1700, and now is dipped down to below 1,000 again, 992, and it looks like it's dropping. The ICU critical care beds really stayed kind of stable. That's what we're seeing now is we're back pretty well to the level that we saw in March. Next slide, please. So if you want to look at it going way back to January, there's what you're seeing on the left-hand side there is the peak during Omicron 1 with a little over 4,000 people on average in hospital occupancy in bed, with 580 in ICU. And then I've shown you the right-hand side of this curve in the previous slide. Next one, please. So one of the things I'm going to do, take you from a snapshot now, is to a little bit of crystal balling, and I'm not going to have anybody hold me to this, because crystal ball prediction is a very dangerous thing to do. So the three things that we can look at about COVID-19 that tell us a lot about what's happening are outbreak numbers, totally, test positivity, and wastewater detection. Remember that COVID-19, like influenza, is essentially a community-based infection. Infections in hospitals happen. There can be nosocomial transmission. We see with the flu, but it's decidedly less common than what you see in the community. So let's look at where things are sitting right now. Next slide. So this is just a daily confirmed outbreak number from April 1st to May 24th, and it doesn't take a statistician to draw a curve here, which shows that this is plummeting. So our outbreaks are diminishing across all of the places that we're concerned about with outbreaks. So outbreaks are decidedly dropping in number, and that's a good sign. Next slide, please. So this is test positivity, and you can see that what we saw with Omicron 2 in Ontario was it peaked at about 19%, but we're now down to yesterday 8.4%. Again, it's reasonable to remember we're testing less people, but the number of people presenting who are ending up positive is a reasonable marker. The orange and green lines represent where I sort of get myself at. I think if you're less than 10% and above 5, you're kind of in a moderate phase. If you go below 5, you're in really great shape. And I say that as from a part of Ontario where we used to be really happy because we were always at about 1%, but I think 5% has become a bit norm. So the next one, please. So what about wastewater? So this is an overall picture of wastewater detection across all of the province. This is from our COVID-19 Science Advisory Table website. And you can see this drop off that's occurring. The dotted lines represent sort of an extrapolation where we think things are heading based on some prelim testing. And then next slide, please. You can look at it regionally, and these are the different regions in the province. You can see the GTA gets its own spot, and then Eastern, where I am, we actually had a higher peak because I think a lot of that was influenced by Ottawa, but all the regions are showing a drop off in wastewater detection. So that's another good sign that community prevalence in general is dropping. Next slide, please. So when I look at these predictors, what I say is I think the outbreak numbers are looking very good, clearly dropping, and I think that's going to continue to be the case. Test positivity is looking better, but I still give it an amber light because we're sitting between 5 and 10%, although we could very quickly drop below 5%, I think, in the next week or two. And wastewater detection looks very, very encouraging. So right now, I guess my prediction for June is that things should look very good. And unless COVID throws us a curveball, which it's been notorious to do, if we can maintain that and rely on some of the seasonality that's known to happen with coronaviruses, then the summer could look relatively clean before we head into the fall. And my general gist of what I know about, because I used to be a coronavirus researcher, is we're likely to see some biphasic surges through the winter season, which will be late fall, early winter, and then a second wave in the late winter, early spring. But those surges could be very small based on great vaccination. The fact that so many people have been infected, we now have what's called hybrid immunity, which looking at surrogate markers looks quite impressive in many ways. So that's where I think things are sort of heading at the moment, and the snapshot of where we were. Now, do you want me to go on to the next stuff? All right, Tara's shaking her head. So let's talk a little bit of vaccination. And I'm going to kind of key in on fourth doses. So maybe next slide. There we go, fourth doses. So what's all the stuff about fourth doses? And I get lots of questions. I know all of us do that are on the panel, and many of you as physicians are getting questions about should you get a fourth dose. And as you know, there are current criteria to vaccinate with fourth doses anyone over the age of 60 in the province, as well as a number of individuals who are immunosuppressed for various reasons. And I think that data is fairly solid on the benefit of fourth doses in those populations. Why over 60? Because although we used to think immunosenescence was a problem really when you got into your late 70s and early 80s, we now know that it exists in people in their 60s in a general sense. There are healthier people who probably don't have much immunosenescence in their early to mid 60s, but as a general rule, many people have that happen. So what about people under 60? So next slide, please. So we're very fortunate that the Israelis did a study where they looked at healthy healthcare workers under the age of 60. They looked at over 1,000, and they assessed the benefit of a fourth dose of either the Pfizer-BioNTech vaccine or Moderna, given at least 4 months after the third dose. So what they saw here was there was an appreciable vaccine efficacy, 30% for Pfizer and about 11% for Moderna. But you can see that the confidence intervals were relatively wide for Pfizer, not so much for Moderna. And what you see in the graph there are just IgG titers measured, and BNT is the Pfizer vaccine, mRNA 1273 is Moderna, and they're looked at varying in various individuals. And you can see that there was an appreciable rise. And I say this because I think I should have prefaced things by saying, without question, I think all of us who know a lot about vaccines would tell you this is a 3-dose vaccine. The sweet spot for this vaccine is getting a third dose, and there is going to be a benefit for fourth doses in select populations at the moment. So there was a benefit, but it wasn't huge. Next slide, please. Same study. So this is now looking at prevention of symptomatic infection. And the two graphs here, the one that's in the middle is the Pfizer vaccine. The one to the right is the Moderna vaccine. And what you can see with the controls were in black, and the blue is the vaccine recipients. And you can see that there's a separation of the curve. It's not as impressive as what we saw with the original VE studies of Pfizer and Moderna back when they were first introduced. And those, everyone's familiar with those very impressive curves as they separated. There was a separation, it just wasn't huge. So what they actually determined was that fourth doses were immunogenic for sure. They were safe and efficacious, primarily against symptomatic disease. But the benefit, the incremental benefit is not as great as what we're seeing in older individuals and those that are immunosuppressed. And then I have 2 more slides to very quickly look at. Let's go to the next one. This is actually from a review that was published in one of our journals, Open Forum ID. And I think this is a really important point. And I have been very involved in looking at the evidence around the efficacy of vaccination against transmission. We talk a lot about, does it prevent infection, sterilizing immunity? Does it protect you from severe disease or protective immunity? And there's clear evidence that it does that. But the other thing that we know, that even when you don't necessarily have sterilizing immunity, you have immunity from transmission. And it's not just because you didn't get infected. There's something about people who are vaccinated. When you look at studies, the amount of virus they shed is lower, and the virus that they do shed tends to be less infectious when you actually do a viral culture assay to line it up. So vaccine recipients compared to non-vaccinated people who have the same viral load, or if you want the cycle threshold on a PCR test, the infective dose in the vaccinated people is a lot lower. So there is this benefit we get from vaccination in that it helps to reduce transmission, which, if you think about it, is probably one of the best things that we have. And just the last slide here is to talk, next one. The last slide is just a paper that just got published about 2 weeks ago, or 3 weeks ago, I guess, looking at viral load values between unvaccinated folks. You can see on the left of this graph, people who were vaccinated but less than 6 months, and people who were vaccinated but more than 6 months. And what they saw actually was that there was a significant difference between being vaccinated and not being vaccinated. And there wasn't much of a real difference ultimately in those who were less vaccinated, more or less than 6 months. So we're getting lots of good data to suggest that vaccination offers this benefit, which is incredibly important to public health. So I still really, advise people that getting vaccinated is really important. If you're young and healthy and under 60, I don't think you need a 4th dose now. And we're looking at bivalent vaccines in the fall. So I would sort of hold off at this point. If you're over 60 though, and you have any of those conditions, you should get your 4th dose. There is an appreciable benefit, which is higher than it is in healthier young people. So I'm going to stop at that point. I think I'm passing it back to Tara.
Thanks, Gerald. That was really helpful and comprehensive. Maybe, Olivia, we'll pause for a moment and we'll just ask, I'm going to do a little bit of Q&A. I think, Gerald, you just ended telling us about the 4th doses and how over 60, it's really important, under 60, less benefit. So Fan Waning is asking, will healthcare workers under the age of 60 be eligible for a 4th vaccine dose soon? It sounds like from what you're saying, we shouldn't need to worry about it, but I do want to ask that. And I think there's also a follow-up question, because one we also have heard is that you showed that data that showed some incremental benefit and efficacy, but our understanding was the study showed that maybe that waned after. So just wanted to also ask you about that too.
Yeah, so I would say don't look for any recommendations right now about healthcare workers being eligible, right? Because it's a matter of eligibility right now. If you're a healthy healthcare worker under 60, you're not going to get the vaccine when you show up because you don't fit into the criteria. I would not at this moment be arguing that healthcare workers who are healthy and under age 60 need a 4th dose, especially with what we're going to be able to watch and see during the winter wave, and whether these bivalent vaccines, so both Moderna and Pfizer have a bivalent COVID vaccine that includes the original ancestral RNA fragment plus an Omicron specific fragment. And I would, if we're going to roll out 4th doses to otherwise healthy people, especially healthcare workers, I would be waiting for those, and once you become eligible, I would push for getting it. Absolutely, no question. The other, what was the other question, Tara?
The other question was about the waning after getting the 4th dose. So that was the other thing that I think others have told us on the COP, and that was potentially also reported.
Absolutely. So I'm a coronavirus researcher, at least I was when I was a young guy, because I'm an old dude now. The fact of the matter is that coronaviruses notoriously do this, and I could give you and show you some excellent papers which tell us this is what happens with coronaviruses. Sterilizing immunity, prevention of getting infected, is always short-lived. With the human coronaviruses, it's about 12 to 18 months. With SARS-CoV-2 and vaccination, it looks like it's about 6 months, so that's been preserved. But protective immunity lasts decades. So the vaccination is going to protect you for years to come from getting severe COVID and getting, in hospital and dying. And that's just typical of coronaviruses. They do this, and the work that's been done by the Dutch, they've followed people for 30 years with coronaviruses to show that this is actually what happens over time. Repeated infections can happen, but you're protected from severe disease by the fact of either a prior infection with human coronaviruses. And I think it's what we're going to see with the vaccinations and some of the observational data that Jeff is going to be looking at, and others who look at administrative databases is going to basically prove that that's the case.
So Gerald, just to confirm there then, so our immunity against infection may wane, so I think that was the question that Alan Grill was asking. So is the immunity against infection wane, 6 weeks or so after that 4th dose?
Yeah, it's not. Yeah, Alan, it's not 6 weeks. Right? If you're, I know Alan. He and I are really good friends, actually. The fact of the matter is that waning with fourth doses, when you look at the data on older individuals, is probably lasting for about 4 to 6 months. So they're still watching it, and it is very, very gradual. So it isn't a quick drop off at 6 weeks after a fourth dose. Now we're obviously going to look at what that means in younger people at some point when we have even more data than is currently available at the moment.
Great. So Donna Shore asks a related question. Any evidence that larger intervals for fourth dose are more effective? Is there an advantage to wait for the fourth dose beyond 6 months?
There may very well be. Jeff mentioned that, and we know in vaccine science that there's a process called affinity maturation that occurs in your B cells and your humoral immunity. And the reason longer intervals work better is your humoral immune system refines the antibody that it initially creates in response to vaccination. And that process takes a little time, but helps to improve things, because what it makes is an antibody that is strong, has higher and higher affinity for multiple sites on the antigen that it has processed. So that's why the biological principle of longer intervals is really, really important. With fourth doses, we don't know. The Israelis have been very quick rolling out third doses, fourth doses. So they're not really good at the interval side of things, but they are going to be able to look at their data and separate out, as Jeff has done with the observational data here in Ontario, people who got a shorter versus longer interval. So we're waiting to see that data and see what it looks like when you tease it apart in those subgroups. I think Jeff had a comment here at one.
Yeah, just a couple of comments. One is the issue of waning. I mean, I think it's not like, VE is good and then one day it goes bad. It's just kind of declines gradually over time. And I think we see that for sure against the infection outcomes because of the lack of sterilizing immunity. But, even against severe outcomes, I mean, we see it less, and it's just against severe outcomes, at least against Delta, it was, declining very slowly, and maybe a little bit more against Omicron. About the interval between third and fourth doses, I mean, I think by that point, right now they're recommending fourth doses in 5 months out after the third dose. And I think whether it's, 5 months, 6 months, 7 months, it probably doesn't make a huge difference. I think it's those, the initial between dose 1 and dose 2 where it makes, between, 4 weeks versus 16 weeks probably makes a bigger difference. So I don't know. I don't think we need to necessarily wait for, to have a better immune response. I think, you'll get with each booster dose, you'll have, an increase in your protection against infection, and then it'll just kind of gradually decline over time. And so I think this is kind of being discussed still. It's like, do we hope that there's good enough protection for 6 months. And so that's why the plan, I think, and Daniel may speak to this, is we're going to try to vaccinate all the vulnerable people again in the fall to get them through the winter, respiratory season. And we may need to do this, annually, just like we do for influenza.
Yeah, and so I think you guys have both also mentioned that we're hoping that there'll be more Omicron-specific vaccine in the fall. Is that right? Some people are asking about that as well.
Yeah, that's the current plan. It's just up to the regulators now to look at the data and decide if they need more data, or if they're happy to just say that the safety data, which is what they're obviously concerned about a lot always, given all the vaccine hesitancy that tends to be out there, if that's approved by the regulators, they should be available by the fall.
So lots of follow-up questions here. So Betty Ann's story is saying, didn't NACI recommend fourth doses for those over 80, possibly 70, 79, but not under 70? And so I think she's like, which recommendation is Gerald referring to? So I think, Gerald, when we've talked, you've said that NACI is re-looking at the data and will be providing a revised guidance in the next few weeks. But I don't know if you have anything further.
Yeah, I would simply say when NACI released that particular recommendation, it was because they had mostly data on older individuals. They were the group that were studied and looked at first in the countries that were rolling out fourth doses, primarily Israel. So now they're going to have a lot more robust data with younger age groups, the young elderly, if you want to call them that, sort of 60 and over. The 60 and over recommendation is what the province has put out, and my look at the data would suggest this. I support that. I think that's an absolutely reasonable thing. Again, not to scare all those people who are over age 60 out there, but immunosenescence is now detectable in your 6th decade.
And so then Alan Grill asked another question. Gerald, with the new Omicron variants, is there a higher chance now of getting Omicron twice? How much time interval are we protected after a first Omicron infection?
Yeah, so Omicron's tricky because when Omicron emerged, actually it emerged with 5 sublineages all at the same time. So that, BA2 is not an evolution of BA1. BA1, 2, 3, 4, and 5 all emerged at the same time. And there were essentially differences within the structure of the spike protein, which allowed you to be infected with BA1, and then you could get BA2, as we've seen in Ontario. And now the South Africans are seeing BA4 and BA5. So it's not an evolution, but Omicron's a bit tricky. So when you get all these sublineages come out, there is a potential for reinfection, seemingly with Omicron, but it's actually a sublineage of Omicron that's causing these other infections. Once you have an infection with Omicron and you've been vaccinated, particularly with 3 shots, you have what we call hybrid immunity, which is quite substantial and likely protects you from getting any further infections with Omicron and having to wait for either an evolution of Omicron itself or the emergence of another variant with a Greek letter. So yeah, it can happen. And the only other thing that's we used to talk about 90 days between a first infection and a reinfection, that you wouldn't see that within the first 90 days. With Omicron, because of all these sublineages that are out there, we are seeing people, potentially reinfected within 60 days, but that's because they're getting reinfected with a sublineage of Omicron, not the same one that caused their initial infection.
That's really helpful, Gerald. So I have one last question, and while you're answering that, we're going to have Olivia pull up the slides where we were. The last question is just Anne Huisman, and I think, Jeff, you answered this, but I think it's worth us answering live. What's the evidence for 3rd doses for kids 5 to 11? Will we see this approved prior to September school start?
Yeah, so I haven't seen the evidence that the FDA saw, but I just know that the FDA did approve it, and ACIP, the ACIP, that's the US's equivalent of NACI, made a recommendation for it. So I think it's going to be just a matter of time before we get that recommendation in Canada, but time will tell. Gerald?
Sorry, actually, I have one other question, and then I'm going to we'll go back to our presentations. Jenny Clement asked, is anyone seeing odd presentations of viral illnesses lately? I'm seeing a lot of diarrhea with fevers and joint pains and some odd rashes and mucosal lesions. And I'm wondering if this is a new variant or not related to COVID.
Yeah, so certainly COVID can cause a GI presentation, and we do tend to see it somewhat more so in younger people. But you have to be careful with the dropping of a lot of public health measures. We've seen the resurgence of a lot of different viruses. If you're seeing adults with, acute onset fever, vomiting and stuff, that's probably noro. We've had quite a bit of noro circulating. In children, we've had hand, foot, and mouth disease presenting itself again, and I think actually family doctors are more familiar with that than even ID docs, since they usually present to your offices and not into the hospital, where we're going to oftentimes pick them up. So adenoviruses also are co-circulating a lot, and adenoviruses produce a variety of gastrointestinal respiratory infections as well. So you are starting to see now when they're coming into your office, people who are having these kinds of presentations. Some of them could be COVID, but you may also be seeing a variety of all those other viruses that you used to have to work with. And I always remember pharyngeoconjunctival fever. So fever with a sore throat and red eyes is an adenovirus, and that's tends to be a pretty classic presentation. So that's probably what you're seeing. I just wanted to finish a comment by saying again, this vaccine is a 3-dose vaccine. That's my bottom line. So if you've had 2 doses, and somebody was asking about 3rd doses for 5 and 11-year-olds, it'll be approved in Canada without question, because it's a 3-dose vaccine. It's a sweet spot. If you talk to my immunology colleagues, they will tell you that that's where you hit the sort of optimum benefit from vaccination. 4th doses will obviously offer a little bit more for some populations, but it's a 3-dose vaccine.
Yeah, I think that's really important. It ties into the slide that we have up here, Gerald, because it shows that, among the population 12 plus, 56% have gotten their 3rd dose. It's 90% in those 70 plus, which is really nice to see. But even if you look at 50 to 69, it's only 70%, and then only 45% for those 18 to 49. So we have further work to do to convince people to get that 3rd dose. Next slide. 4th doses, of course, we have even further to go. So if we look at 60 plus 4th doses, only 20% of folks have gotten it, that 4th dose. And we're hearing from Gerald today that it is a good idea to go get that 4th dose if you are over 60 and you've gotten the 3 doses. Next slide. And then, of course, 5 to 11, I think Jeff showed some really compelling data about how it is protective for specifically also severe outcomes, which are rare, but rare, but there. So, and what we saw is that there's a lot more protection with 2 doses versus 1, and only 36% of Ontario's children 5 to 11 have received that second dose. Next slide. And then I did want to highlight especially our immunocompromised population. Unfortunately, these are people who definitely need a 4th dose or should be getting a 4th dose. And we see, even the 3rd dose uptake in many people with immunocompromise is not as great as it should be. And certainly we need to do better from a 4th dose perspective. So lots of work still to be done. And I know all of you are working hard to educate your patients, and hopefully the work what we provided today will help. Next slide. If your patients need more information, please do refer them to this new updated Confused About COVID handout that we have. Next slide, and then we're going to start on monkeypox here. So we're going to transition to monkeypox. We were planning to end at 9, but I think we may end up going a little bit over 9. My guess is till 9:05 or so. We do have about 900 attendees on the call today. So thank you for your patience as we try to get through everyone's questions and address some important issues. But I'm going to turn it over to you now, Gerald, because I know there are a lot of questions people have about monkeypox, and you're going to give us a bit of an overview.
Thanks again, Tara. For if you don't cover everything, talk to Alan Grill. He got interviewed the other day on CTV. And Alan, you did a fantastic job of summarizing monkeypox and answering all the questions. You got it bang on. Not surprising, of course. So I put Redux on this because for some of us who have been in ID doctors for a long time, we actually saw monkeypox back in 2003 in the United States. And so it is a bit of a re-look at what monkeypox is all about. So let's quickly discuss it in general. Just a quick note, it's called monkeypox because it was discovered in monkeys that were in a Danish research lab in the late 1950s. It's actually not necessarily the reservoir for it, which we'll talk about in a second. The very first human case was described actually a few years later in 1970 in a small child. And since then, it's been reported in 11 countries, principally in Central and West Africa. Recently, and this is of pertinence to what we're talking about, the Democratic Republic of Congo, Cameroon, Central African Republic, and Nigeria have actually had an outbreak involving more than 1,200 cases since December 2021 through to May 2022. And it's likely the genesis of where this emerged from, probably related to travel. And as you can see, they did have some deaths, and we'll talk about what sort of predicts bad outcomes with monkeypox. The 2003 outbreak in the States was the only previous time that we had seen monkeypox infections in humans outside of Africa. And the outbreak was actually associated with the importation of wildlife, particularly Gambian pouch rats, to wildlife markets in the United States. And they infected prairie dogs, which were housed next to them. The prairie dogs were adopted as pets by people, and then it ended up producing about 47 cases. So next slide. These are actually some pictures of the cases from the monkeypox outbreak in 2003. On the right-hand side, you can see a small child's hands. This was a child who probably had got inoculated from handling an infected prairie dog. And the pictures on the left are actually the father of that child who developed 2 small discrete lesions on their chest. There's a little bit of a close-up there to sort of show you what it looks like. And that's very pertinent what we're going to talk about because, we see the pictures of some monkeypox patients in Africa, and it looks like smallpox. I mean, a massive centrifugal rash. But the fact of the matter is that we're starting to see, and we saw in 2003, fairly mild and atypical presentations. Sorry about the National Enquirer headline, but I couldn't resist throwing that one in there. Next slide. So monkeypox is caused by the monkeypox virus, which is one of the pox viridae. So it's related somewhat to smallpox and vaccinia virus, which is what causes cowpox, and which is where we get the derivation of vaccination from, introduced by Edward Jenner in the late 18th century. And so there's a lot of similarity in the the electron micrograph you see on the right. The mature viral particles are those oval dark-shaped ones on the left, and these rounder ones are immature virions that are undergoing their construction to become more mature ones. The key thing to remember is there's actually two clades of monkeypox virus. There's a West African clade and a Congo Basin clade. The former one, which is the one that we're seeing now in the outbreak in 2022 around the world, is of the West African clade. And although the reports of mortality up to 3.6%, that's principally in Africa. When you look at it in general, it's probably about 1% and may in fact be lower in higher socioeconomic countries where medical care is much more readily accessible. The Congo Basin one has a fairly high mortality rate of 10%. And to put it into perspective, for those of you who remember smallpox, and there's not a single person on this call that has ever seen smallpox. I'm probably older than almost everybody, and I haven't seen smallpox. The variola major form of smallpox actually had a case mortality rate of 30%. Next slide. So these are the countries, and you can see there's four maps here. The top left one is from 1990, before 1990 up to 1990. The next one to the right is 1990 to 1998, 99, and then 2000 to 2008 is the lower left, and 2010 to 2017 is the one on the right. So you can see that the West African clade dominated early on, kind of tended to die out a little bit. We had the Congo Basin clade, and now we have both clades sort of arising. So next slide, please. So this is actually, I can tell you, an update from yesterday. And this shows actually, if you look at the sort of there's 20 countries that have reported confirmed cases, 21 if you include Argentina that as of yesterday had a suspected case. That totals 322 laboratory confirmed cases. These are all obviously non-endemic countries. They're chiefly European, including the UK. There's two Middle Eastern countries, Israel and the United Arab Emirates, Argentina with a suspected case, and then you have Australia, Canada, and US sort of taking up the rest of the slack. What you can see here is that these are countries, most of them in the developed or higher socioeconomic countries. This is related to travel. So this is the emergence of a pathogen into individuals who then later on returned to other or traveled to other countries and are probably the genesis of those particular cases outwards. So, you know, there are specific, the largest number of these individuals tend to be young men. Next slide, please. So transmission, I think, is really an important thing to talk about. It is not as contagious as smallpox. And smallpox was really probably one of the quintessential, you know, aerosol transmitted / airborne infections that we knew about. The primary route we're seeing is contact with body fluids and lesions. Yes, you can detect virus in respiratory droplets and in the upper respiratory tract as well as the blood. And we also know that fomites, so material that's contaminated by lesional material, can transmit it. With animal to human transmission, it's always the usual thing: bite, scratch. In Africa, if you're preparing bushmeat where you're perhaps have a rodent that's endemically infected as a reservoir, you can get it. Next one. So that leads us to what should you do at the moment. So at the moment, we're recommending a full sort of PPE protection with including aerosol protection with an N95 mask, ideally fit tested and seal checked, along with proper hand hygiene, gown, gloves, and eye protection. And if you're I'm at work in a hospital, we're going to be, you know, having people making sure they know how to don and doff properly as they leave. And in the hospital environment, we're going with airborne infection isolation rooms. Most hospitals have a number of them, or at least a private room. You have to use dedicated medical equipment, and remember that you have to remove non-essential items from an exam room or whatever, and make sure that it's thoroughly cleaned afterwards. Next slide. So signs and symptoms. So this is just the traditional presentation of monkeypox. It actually has two stages. There's a kind of sort of viremic invasive phase, which typically has symptoms that are similar to what we would see with quotes flu-like illness, lacking typically the respiratory symptoms, so fever, headache, myalgias, and fatigue, along with lymphadenopathy. And you can see in the lower right corner an African patient who has some posterior cervical lymphadenopathy that's present. That's followed usually about 1 to 3 days later by a rash phase, in which you get this centrifugal rash. It looks a little bit like varicella, except varicella is centripetal, and it evolves through the typical stages we're all familiar with: macules, papules to vesicles and pustules. What's interesting is the reports that I'm getting from my ID colleagues around the country, including Quebec, where they have a large number of cases, at least comparatively, is very atypical presentations with single lesions sometimes, and not sort of these multiple lesions. And again, you can see in the person on the top here, they just have 2 lesions on their hand, as opposed to the middle picture, which shows, again, an African patient with multiple lesions, some of them which have already broken down and formed small ulcers, which often heal with a scar. So I think that's important to recognize too. So I would just emphasize there's atypical presentations. Next slide. So laboratory testing, I'm going to go very briefly over this because Daniel's going to talk about it, but basically Public Health Lab is ready to receive samples. They just want to point out that they want to have some notification. And this is actually from the reference at the bottom. That's the website you can go to. They will help with notifying public health units of suspected things as per the CMOH order. Next slide. Lots of things, you can collect lots of stuff, and it's very easy to spot with PCR. This is not a shy virus. In the invasive stage, when you don't have skin lesions, you can do a throat swab or a nasopharyngeal swab. You can take serum and even whole blood, and we can amplify that. If there's a rash, you can take samples by unroofing lesions and collecting some of the fluid that's underneath there and sending it off. The advantage of that is that we can do an electron microscopy examination. These are big viruses. They're really easy to spot with staining with phosphotungstic acid, and you can spot it. If the patient's gone beyond all that stage and they're now healed and they're post-rash, then you look at convalescent serum to look at a serological assessment. Next slide. So risk factors. It's important to point out that if smallpox vaccination protects you, and yes, people have talked about, well, wait, maybe it won't because, you know, people like me, for instance, got my 3 smallpox vaccinations in the 1960s. But I would suggest to you that there's probably pretty good evidence, given the nature of this virus, that you're likely to be protected if you had it. But if you're under age 50, you probably didn't get smallpox vaccination because that got stopped. Ontario, I believe it was 1970 or 1972. I don't recall. Bad outcomes typically occur most commonly, at least we've seen in Africa, amongst children, but people who are immunosuppressed and pregnant individuals where there's a relative immunosuppression due to pregnancy may also develop a more significant outcome. So we have to watch that. Contacts, of course, we'll have to be managing, and that's really important because ultimately one of our strategies may be ring vaccination, which worked very effectively during smallpox eradication processes. Next slide. So very quickly, treatments, there are treatments available. Unfortunately, I did this slide deck and 15 minutes later, I saw the Lancet paper where they examined 7 monkeypox patients in the UK and looked at the efficacy of cidofovir and brincidofovir, which are investigational compounds, and actually showed a substantial reduction in viral loads and an improvement in symptoms. Very more specifically, we have tecovirimat, also known as TPOXX, which is actually a smallpox treatment, but is approved in both Europe and here in Canada to treat monkeypox. And the feds have made some of that available already to our colleagues in Quebec to be able to treat it. And there is also a specific smallpox attenuated live virus vaccine called Jynneos or Imvamune, and we have that approved here in Canada and available as well. And so that may be part of a ring vaccination strategy that will eventually bring into play in order to control numbers. And that's, was and is a very effective strategy. When you have a disease like this that has an incubation period of 1 to 2 weeks, then if you can spot a contact within a day or 2 of their exposure and you vaccinate them, the immunologic response may be fast enough to either abort the infection or may in fact really substantially reduce the likelihood of that person who got vaccinated as a contact from going on to transmit the disease, even if they develop it. So I think that's one of the other important things. So I think my last slide, which is the next one, is very quickly, I would just say keep calm and don't panic. This is not COVID-19. I fully don't expect that will be a pandemic. And I think I feel pretty confident in saying that. So I'll stop at that point and hand it over.
Thanks, Gerald. I'm going to hand it straight to Dan, and we'll just go. Dan, I wonder if you want to pick up where Gerald was.
Yeah, I'll be really quick, and just to build on what Gerald said. So in terms of viral testing, this is the detail. So we can't do the testing in Ontario. It has to go to the National Microbiology Lab in Winnipeg. So the details on how you would go about getting that test done are in the test information sheet that's on PHO's website. The important thing is you cannot do the test in your office. So this is classified as a category A pathogen, which means it has to follow very specific requirements in terms of IPAC and packaging. So if you do have someone who thinks needs testing, you should contact the local public health unit right away. The testing needs to be done in a facility that will appropriately do the test and package it to get it done. Otherwise, it will be considered an invalid sample and can't be tested. So that's the main thing about testing. To go to the next slide very quickly, just again, in terms of the reporting requirements, the COMH order has gone out. There is a case report form that's available online and attached to the order. And so I think Tara has put that information for everybody available in the chat just so you can access it. Next one, please. Case and contact management guidance has gone out to all the local public health units and should be posted relatively soon. Here are essentially the details. So in terms of case management, people are isolating at home until the end of their communicability. As said here, contacts are needing to isolate for 21 days from their last exposure. And so again, local public health units will be following up with all cases and contacts. And then next slide, just to quickly build, I think I have one more on vaccines, but that's okay. But to quickly build on what Gerald said about the treatments and vaccines that are available, right now, in terms of what we actually have, so not all of those vaccines and treatments are available that Gerald mentioned. So Tecovirimat is the one that we do have a very small supply of at the federal government that is available for Ontario if needed. So that's something that would be determined based on the treating physician working with the local public health unit to order it from the federal supply to have available. So that would have that one works. In terms of the Imvamune vaccine, we have about 2,000 doses available in Ontario for use right now. And again, that would be for ring vaccination of contacts who are higher risk, as determined by the local public health unit who would be ordering, and then administration would be done either by local public health or through primary care provider to get them the vaccine if that's the easiest way for the patient to access. It is a frozen vaccine it's ultra frozen storage, same as the initial COVID ones were. So it will have to be in one of those ultra freezers until the time that is going to be administered. That's everything from me.
Thanks so much, Dan. So I think we'll stop slides maybe, and I'm just gonna just mention one thing. I did have a colleague at St. Michael's Hospital who had a patient who was diagnosed with monkeypox, and I just felt like it's an interesting story and lessons and pearls that she provided. So Shelby Jairani, with permission from the patient, has given me a little bit of a case to provide to the group here. This was a 40-year-old man that she saw who had a sexual exposure, oral and anal intercourse, and presented a week later with one lesion above the upper lip and 2 in the genital area. So as you said, Gerald, it wasn't a rash fully disseminated. And actually what was different in this case is that the rash presented prior to the systemic symptoms. So there was a right submandibular lymphadenopathy. The lesion on the penis was ulcerated and not painful. There were subjective fevers, but afebrile in the clinic. But once he was admitted, he developed systemic symptoms followed by a diffuse rash. So an interesting flip of some of the presentation. There was a positive travel history to Montreal, I think, which was what also twigged the clinician in this case. And so some of the pearls that Shelby shared with us was just, taking a travel history is important, but at the same time, of course, it is now here. And so, even in the absence of travel, this could be being transmitted here in Toronto. It's still important to consider a wide differential, so herpes, chancre, syphilis, etc. And I think she makes the important point about how we do need to protect our gay community from stigma. That this is something I think Alan put in the chat that could affect anybody with sexual intercourse or close contact. And as you said, Dan, the actual testing had to be done in the emergency room. So I thought that those were some good clinical pearls based on a real life family medicine case. I don't know if you guys have any, so I do think there's a few other questions about monkeypox that I wanted to get to. One, Bruce Herman said, can monkeypox be transmitted through touching gym equipments, using sauna, etc.? And should gyms be avoided?
Oh, we're back to gyms again. That's a bigger COVID question than it is a monkeypox one. Yeah, this is a virus which pox viruses in general tend to be very environmentally stable. So contaminated items in the environment could potentially cause a transmission event. I think right now the prevalence is so low. I mean, we're still talking incredibly smaller numbers that, you know, the likelihood of a chance encounter out there in the real world, like if you go to a gym or you're, you know, out and about with your shopping and other activities, I think the likelihood of seeing a transmission event from that is extremely low. It's not zero, but it's extremely low. I don't know if Daniel wants to sort of toss in on that. He's the public health guy. I'm just a goofy infectious disease guy.
No, everybody trusts you more, Gerald. You're the one who's done it for the past 30 years. No, but I agree. Nothing to add. We're not concerned about surface transmission at this point.
Thank you. Andrea Hollander says, can you please clarify the difference between the vesicles for chickenpox versus monkeypox?
Yeah, so chickenpox is caused by a herpes virus, right? Varicella zoster. So they tend to be very small, thin-walled vesicles. There's not a lot of induration, whereas monkeypox, like smallpox, is a very indurated lesion. It has a thick crust on the top, or thick capsule, and they're a little bit more difficult to unroof than the very flimsy, light one that you tend to see with varicella zoster. And again, it goes back to the, you know, when I was in medical school, we got taught the difference between chickenpox and smallpox, and that's essentially you're back to the same argument. And again, in chickenpox, it's a centripetal distribution. It tends to be more on the center part, where like smallpox, monkeypox tends to be centrifugal. So you see it on extremities, in the face, and other places like that. But, you know, Tara's case that she presented from her colleague, that's really important to understand. I mean, you're going to see small lesions. All of us in practice have seen chickenpox where one kid is clearly covered in chickenpox, and their sibling, who also got infected, has like 12 lesions on their head, and it's all in the scalp where you can't see, where you don't see them unless you go looking for them. So that's essentially the difference.
Fanwa Mang says, can you explain the difference between a centrifugal rash and a centripetal rash?
Yeah, so centrifugal means it goes out to the extremities, right? So the rash tends to be more prominent in the extremities away from the trunk. A centripetal rash is heading towards the center, so you see it more on the trunk and the body.
Okay, and then I think Diana Ahmed did have also a comment on, you know, can you comment on the accuracy of the report saying that monkeypox outbreaks are most common in the gay men and bisexual community? And I think I addressed this a little bit, but wanted to.
Yeah, no, if you look epidemiologically, yes, there appears to be a fair number of individuals who would identify within that group. It's a bit of a, and I noticed that Howard New, my ID colleague, who's the associate medical officer of health for Canada, commented, you know, we don't want to stigmatize and to say that's the only group it's appearing in. It isn't. We're seeing it outside of individuals with that particular demographic. On the other hand, we are trying to make sure that populations of individuals are aware that there's a potential for transmission, and that probably relates to the fact that in social interactions with people within that group, there's a lot of close contact. So you're going to see transmission of this virus if you have close contact with someone. If you're near them and you're chatting and talking, or even perhaps engaged in more intimate activities, that's a great way to transmit monkeypox. So that's the sort of thing that is there. But we really want the public to be aware that you have to be very careful to say, oh, it's only happening in that group, I don't have anything to worry about, because that's what we're tracking and watching and seeing. And that's why the importance of what our public health colleagues are doing is so pivotal to being able to get control of this, which I think we will be able to. I don't think there's any question.
And then one last question from Esther Liebman that says, are you contagious with monkeypox prior to developing symptoms?
Probably. The viremic phase is associated with the onset of fever and some of those systemic symptoms. But if you look at some of the studies in Africa, they did show that you were able to recover virus from respiratory sampling of either the nasopharynx or the throat in the day prior to the onset of those symptoms. Although most sampling has been done once symptoms developed in individuals, but that would be very typical of many viral diseases. We've talked about it with COVID. We know it happens with influenza, although a shorter interval. Many viral infections are transmissible in a period of time time, perhaps about 24 hours prior to the onset of overt symptoms, which tell you that the patient's infected.
Okay, and then I think just to end with this sort of, I guess, the questions that people have about, infection prevention control. If we're seeing someone with suspected monkeypox, how do we disinfect after seeing them? What if we don't have a negative pressure room? My understanding is that this is, these are people we can still assess in the office, but that the testing specifically requires us to send them out to a place that has a negative pressure room and can put the precautions in place. So just wanted to clarify that for our colleagues from a practical perspective in our offices.
Yeah, it's a good question. This virus is very susceptible to what we call low-level disinfection. So if you have a protocol to use a variety of different things in an exam room that a patient's been in, if you just ensure that that room is cleaned with those low-level disinfectants, you will really negate any overt concern. And of course, if you're seeing the individual, fortunately, in most family physician clinics, you don't see multiple patients in one room. You should put on your PPE, gloves, gowns, hand hygiene, eye protection, and a mask. If you have an N95, go for it. Then just clean the room with low-level disinfectant afterwards, and that'll be fine. Thank
you. So I'm going to ask Olivia to bring up our second last slide, just to let people know that the OCFP Family Medicine Summit is coming up, and there's deadline for abstract submission, and you can join the planning committee, and more information is going to be in the chat, and deadline for both is June 12th. Next slide. We haven't confirmed, we're having some problems with figuring out a June date. We thought we had landed on one, but aren't sure anymore. So just stay a lookout. We'll of course keep you posted on when our next session will be. So thank you for that. And of course, when we're going to be sending out an evaluation after, and we always appreciate your suggestions for topics for future sessions. I wanted to give a huge thanks to our panelists today. Gerald, if you've seen the chat, you would have seen lots of comments, people thanking you for that really terrific presentation on monkeypox, and then all of you, and Dan for that very practical information, and then all of you yourself, Jeff, Dan and others for the information on vaccination, which I think was very helpful for everyone as well. So thank you for making the time today. Thanks to everybody who continued to attend. I know you continue to find these sessions valuable because we had 900 people join today. So what a wonderful community we've built. And I want to thank our VAC team and our co-hosts, Liz Maga and David Kaplan, and all our organizers behind the scenes, including Olivia Neal, who staffs the slides, who really helped to make all of this happen. And of course, thanks to all of you who do the hard work of seeing patients every day. And hopefully these sessions help you to do that with even more confidence. Thanks, everyone.